Hello, thank you, Matt. The title of my research is lovely and long. The business of medicine, using critical discourse analysis to explore the constructions of identity and information practices among Australian surgeons transitioning between training and professional practice. Now, don't worry, I'm not going to get bogged down in definitions and theory. I'm just more interested in explaining to you what this is really about and why it interests me. But I am going to start by giving you my research questions because this is a complex area, and so I want to show you where I'm focusing. Because that's ultimately, I can only really focus on a very narrow set of questions. So my primary question is, how does professional identity shape the information practices of surgeons? And the secondary questions to that are, what are the different professional identities that surgeons enact in their engagement with private practice? In what discourses are these professional identities situated? And how do these identities relate to their information practices? Now you can see the term information practices is there multiple times, and also identity practices. Because we're a room full of information professionals, I'm going to focus more on the identity aspect of the work. Now, my research focuses on two key identities within this profession of surgeons. The first is the, clinician, medicine as science, the tradition, the prioritising of patients, the knowledge, the teaching that goes into being a practitioner of medicine. And the second identity is the identity of the entrepreneur, of medicine as a commodity, of how I sell my knowledge and my skills and my expertise. And that tension is what's going on in private practice, every day of the week. So surgical fees are a hot topic, you may have noticed. A simple Google News search just in the last couple of days has given me, I could grab many different stories focusing on the topic of fees. And some of you may have seen the Four Corners investigation by Dr. Norman Swan on Mind the Gap, focusing on who's really to blame. I love that it's who's really to blame, not what's to blame, but who's to blame for mammoth medical bills. And so with that comes a bit of disclosure. So Matt introduced me. You have an idea that I'm not just experiencing this as a researcher or as a patient, but I'm the director of a medical practice, and I run that with my partner and husband, who is a head and neck surgeon. I set up, the practice has been running for 20 years. I set it up from scratch. And so over the time that we have been together, so I knew him before he even applied to be a specialist surgeon on his particular training scheme. We've walked the career path, which now involves him being, he's been national chair of training for his specialty and a board examiner, as well as the private practice road and the nitty-gritty that comes with running a business on a daily basis. Now, I want to give you a bit more about the research participants and the site of this research. So the majority of Australian surgeons are self-employed in private practice. In some specialties, this is as high as 95%. So the majority of surgeons in Australia are working in private practice to some extent. And they participate in an average of 12 to 14 years formal training in order to qualify as members of their profession. That's a long time. That's a lot of formal training, a lot of formal knowledge. And by contrast, they receive little or no formal training in how to establish and manage a private practice. And the other point I want to make is that only 10% of surgeons are female, compared to 40% of all medical practitioners. Now, the College of Surgeons refers to this group, who are newly qualified, as younger fellows. It's their terminology, not mine. It's because when you join me, you are admitted at your convocation, you become a fellow and you have a fellowship. And so I'd like you to meet a few of them. Let's sort of, keep them real. Here I am with Alok and Julia. And they qualified as specialist surgeons, so Alok in 2017 and Julia in 2013. This was taken last month at the college's annual scientific conference. And so Julia completed an additional advanced surgical training fellowship for a year in Tampa, Florida, where she trained in transoral robotic surgery. And that's not unusual for surgeons to go on and do additional training after they have qualified. And so that means that most of them are aged in their late 30s by the time they finish their training. Alok, for example, he and his wife are both ENT surgeons, and they have gone directly into private practice with no advanced surgical training. And I can talk to you about Alok and Julia because they are within the specialty that I don't talk to. Because I'm actually very protective of the privacy and confidentiality of my participants. And it's part of my ethics approval that I don't speak to any participants who are in the same specialty as my partner. I checked with them, they were okay. And so there are limited appointments available to teaching hospitals. So teaching hospitals are where these people are trained. Teaching hospitals have been their home, even though they will move from one to another for 6 or 12-month placements. This has been the organisation that they have been a part of for many, many years. And a teaching hospital appointment is seen as highly prestigious, but also is viewed as being a way of ensuring that you are more likely to get quality referrals to your private practice if you have such an appointment. But of course we have, as you may have heard, a large increase in the number of medical students over the last few years, but not an increase in the number of training hospital positions, and in fact they are decreasing. There are very few surgeons who have a full-time position within a teaching hospital in Australia. So often my research participants, they are scrambling from, I'm trying to get a VMO appointment, that's a teaching hospital appointment, I'm not sure where to set up practice, do I go into a group practice, I've got an offer over here, I'm doing a locum there, are they going to make me an associate? So often when I go to meet them, they may say, oh look, I can't use that room to talk to you because there's someone else seeing patients that day. So they are in that scramble transition world, although some of them are actually quite very quickly have been planning where they're going and get there very fast. So just to recap, identity and information practices is where I'm interested. And so what I'm particularly interested is how, constructions of knowledge about the balance of tensions and contradictions between surgeons' own sense of self and the various professional discourses they're in. So there are contradictions, there are tensions. How do I navigate that? How do I make sense of that in a world where I haven't got any formal training for a lot of the stuff that I have to now put into practice as a professional? So I'm just going to touch on the relationship between knowledge and identity practices is already established. That's debatable, I know, but let's just leave it at that for now. So to quote, this is an article that's only appeared in the last couple of months, exhortations to share knowledge often falter, i.e. because people define themselves through the knowledge they create and may feel threatened or vulnerable in the face of calls to share it. I am what I know. That's a particularly critical when the identity of being a doctor or a surgeon has so much prestige attached to it and occupies so much of your life. And then also, conflicting but compelling identity prescriptions lead people to construct identities that broker identity tensions in ways that promote new or reinforce existing institutional forms. So that's interesting when you think about the tensions that exist between the different generations of surgeons as to who is regulating within the profession formally versus who are coming through at the newer fellowship level. So in other words, there are rules that people are expected to follow. So my questions for you, I am relying on most of you having previously met the plastics as they are, they call them, I don't know if they actually do call themselves that, but that is how they are identified by others. Who gives the plastics their power? Who regulates their behaviour? And how do the plastics shape the identity of others? So they're in a school. It's not part of the curriculum that they be in charge of the social scene. There's no one who's actually voted them into that position. But it is a collective agreement that, yes, they are the plastics. Who here would be game to wear pink on Wednesday? No, because we know the rule, and therefore we will follow the rules, because now that we're aware of the rules, we are kind of thinking of the consequences of breaking the rules. So this shaping of appropriate individuals, if we take it out of North Shore High and go back into the world of surgeons, we can do that in all sorts of formal and positive ways, like giving awards. And, we can celebrate when there's a breakthrough in terms of who we see as the face of surgeons. But then there are also lots of other ways that we shape individuals to be what we consider to be appropriate. And this has implications for information practices. It has implications for whom who do we align ourselves with? Whom do we trust? And in what way do we take one set of information and agree that that person becomes an expert and therefore is an expert in all things that I agree in, because I walked into an operating theatre and I saw what they were doing and I went, I want to be like you one day. No further questions asked. And then it also has implications for formal training. And I just want to briefly mention that, so in trustable professional activities, EPAs is a system that's being introduced to medical schools or medical training schemes around the world. It basically relies on a system that says, I, as your supervising surgeon, will assess whether or not you can do a task based on whether I'd trust you to do it if I wasn't there. Now, within the literature of EPAs, the only definition of trust that appears is the dictionary definition. So when we talk about unconscious bias, about all sorts of other implications for trust, and we think about the face of surgery, which has only got 10% women, then we can start to see how there may be some stumbling blocks when it comes to mentoring, and how the regulating of identity, the regulating of information and power all interplay. But the great thing is that the individual retains agency, and this is a constant process, and we're all doing this. We're all accepting and resisting the different identity work that others are trying to apply to us. Maybe it's the way we don't wear a tie, maybe it's the way we wear bright coloured socks, maybe it's the way we spell organisation with an S instead of a Z, but these are all micro-anticipations, and these are things that I go looking for within the data I'm collecting in the interviews I'm conducting. So the moments where I'm the participants are distancing themselves from an idea or saying, I want to do that differently. And then as I build up into more data to see at what points they're singing from the same hymn book. So that's where I'm up to, is I'm recruiting participants and collecting data, or one leads to another, in semi-structured interviews. And I have in principal support from the College of Surgeons, and they've also invited me to apply for a research scholarship. That's the Academy of Surgical Educators. And that's important because I am, in their terms, a layperson, and they've made a special dispensation for me to apply for a research scholarship. And I think that's very telling of the way that the college is wanting to step beyond its existing research practices, but also how entrenched it has been in using its own methods to research itself. So any questions? Chris?
Firstly, congratulations on being asked to apply for your scholarship.
Thank you.
It's a significant achievement. I was just wondering, in your participants, one of the things that came through quite strongly in my research was culture and how that affected the social construction of information. So, are you looking at different specialties?
Yes.
And do you think that different cultures exist within different specialties?
Yes, so it gets interesting. So, okay, we can define medicos against the layperson. Let's break that down. Surgeons against physicians. Let's break that down. You know, you've got 9 surgical specialties within RACs. There are other surgical specialties not controlled by RACs. So it's like I was speaking to a participant the other day, and she said, well, when I was doing general surgery, I walked into one theatre and they were all wearing gumboots, and I said, why are you wearing gumboots? And they went, oh, you'll see. And that was the urologist, and yep, urine went all over the floor. And then I went to the next theatre, and that was ENT, and there was just snot everywhere. And so then I walked into the next theatre, and there was this gorgeous plastic surgeon, and you know, she was just repairing an ear tear, and then we had to do this. So there are already a lot of existing norms, all right? Orthopods are big and strong because they break bones, and you know what? That's how those things are so far from what I'm actually finding that it's really nice to be leaving those at the door, because it's far more complex than that. Yeah, so in this, getting to speak to surgeons from multiple specialties and in private practice or with an appointment or not, it's far more nuanced. And so that's why, until I have more data, I won't be able to... I don't think the distinctions that they are making is not between specialties so much. It's against other surgeons within their specialty often.
So Shona, Dean's got a question.
I just wondered, what are the surprises so far?
Yeah, that's a good question. So while this is a small snapshot in terms of the total career span of these individuals that I'm looking at, the differences in the stages of those individuals is enormous, and that influences how willingly they are to talk. So, which is not surprising, but it was just straight off the bat, in that surgeons who are doing often they have what's called a temporary locum appointment to a teaching hospital. They just, when I stop recording, a whole lot of other stuff comes out, because they are they know there is so much power being exercised in regards to their future. Whereas those who have let go of that, very early on and walked straight into private practice, they're just... but speaking highly respectfully of their training. And that's because it's a constructed narrative. So what they're doing is that they've reconciled with the past, even as they wipe a tear away from their eye, and think, oh, yeah, right, yeah, but I defend it to my patients. Yeah. So I think that's it's even with such a tight snapshot of participants, it's very complex.
Is there a less secure job title than temporary locum?
Yes, I know. It's
particularly since it's literally a tautology.
Yeah, I was waiting for you to use that word. I know it's.
Yeah.
I know, and I understand that, because it does come down to funding. It does come down to budget cuts.
Can I ask you the two identities you identified at the beginning?
Yeah.
Have you got any findings in relation to the clinician versus the entrepreneur?
Depends where they are down that pathway, and depends how much they are in public versus private. So if they're entirely in... So this is only going on a very small amount of data. But if they have a public hospital appointment, then they've got 2 tracks running in their heads, right? I see my public patients and I maintain my public responsibilities in my public appointment, and then I also do work in the private sector, and that's a whole different ball game. Whereas it's really interesting talking to those in the private sector who have to reconcile they retain the same idealist views of how they serve people. So my questions are, how do you choose whom you bulk bill? But, you know, often for them it's like, oh, it's really hard. And the body language is like, I just want to distance myself because I want to focus on being a clinician. And what ties on to your question and goes back to Dean about surprises is this realisation that when you shut down a topic, so because remembering that there's anti-competitive legislation which prevents surgeons, even within the same practice, discussing their fees. So the college says, we don't teach you about private practice. So when you shut that conversation down, when young surgeons want to have a conversation about it, it feels like a taboo topic. And it feels like even mentioning it makes them look like they're money grubbing. And I'm paraphrasing interviews when I say that. So there will be things ahead in terms of what happens in the vacuum, because that's what's really, you know, what happens with highly trained people in a vacuum when they're still working in the expert and the novice identity.
So that's actually just an interesting point. So they've gone through years and years and years of medical and surgical training, right? But they haven't gone through anything about being an entrepreneur, being a business person or anything around that. So where do they get that from? Is it all just kind of secret conversations? Is it with their special mentor? How do they get it?
So there are so many different scenarios. I mean, part of the landscape is that there are a number of business operators who see this as an opportunity. And so there are very expensive advisors. We'll market you. Very expensive practice managers. We'll come and run your practice.
Agents almost, they sound
Agents,
like.
yes. So because the College of Surgeons runs a preparation for practice course, but you're not allowed to attend that until you have actually qualified. And so for many surgeons, they're saying, look, I need to be planning this stuff well ahead. So a lot of this comes into family relationships. So the dynamic of me working, with my partner is not uncommon. And then it's interesting. So I'm also capturing a lot of information about what parents have done as roles as well. So this is where it's interesting. You come down to say, well, because that's the question I'm going for is who do they trust and why do they choose to trust that person? And the person whom my most recent participant really relied upon said, well, he said I did that particular job, and she was describing an appointment in a private hospital where all of the practitioners, so even though she was still being trained, everybody was a private practitioner. And she said, they treated me like a colleague. And she said, and it's because they saw me that I actually was going to be a colleague within 6 months. And they made me cups of coffee. And they showed me around their rooms, and no one had ever done that. She said, so she speaks to them about for advice.
So is there an element of imposter syndrome in their thinking?
This is a well-recognised issue by the college. So I attended the Younger Fellows Forum at the RACS meeting in May, and this is true throughout the world as well, and there's well-documented evidence in Canada. So what the term is that the college uses is competent but not confident. So there's a lot of research on why people are qualifying but not actually going into work. And because, of course, they are training for such a long period of time, and it is so incredibly difficult to get into these training schemes. I mean, I'm sure other things will emerge in terms of gendered practice, because the number of times I'm hearing, I'm so lucky I got on, I'm so lucky this, I'm so lucky. When in actual fact, the CVs of these individuals and the drive to get them through. I mean, with somebody I spoke to recently decided halfway through one surgical training scheme that really wasn't for them, and so they started from scratch with another surgical training scheme, and I've heard that multiple times. And so my own partner was lined up to do 3 interstate and overseas fellowships, so a year of each. So, and ended up, came back to Australia early because he was offered a permanent teaching hospital position. So it's, that competent, not confident is a well-recognised phenomenon. Yes, Maureen?
Just a simple question. When you gave the statistic of only 10% were women across the board, when you expressed what some of the participants were expressing, I'm so lucky, is there a difference between a male's expression of being lucky and a woman and women?
It's a good question, and I think that I'm sure will emerge. And so Yeah, it's listening. So that whole, we know within identity practices that there is that reconciling of the past. And we're not looking at it as a gospel version of account. It's a narrative. And so, you know, it raises an interesting point, is that the way people reconcile how they... Because I'm already hearing in my head, in answer to your question, a male participant who said, yeah, well, I just happened to be here and I happened to fall into that. And so these are the sorts of phrases which, you know, I just smile a lot and just get them to keep talking. Yes, do fit that same mould, yeah. But because I think also what will emerge as being an organisational discourse that they're all repeating is that I am so lucky to be doing this. I have a duty now to use these skills. I am here to serve. So that's guesswork, but it may emerge.
Thank you. I look forward to the final results.
Do you want to say in relation to that when you asked the female about how many experts there were in her field?
Yes, so I asked a female how many experts there were in her field in Australia, and this is a particularly advanced skill, and she said, 7. I said, because I know her, I said, did you include yourself in that? And she said, no.
That would not be surprising to me.
Okay. Thank you very much, Shona.